The RDI's concept is essentially to take the experience of hundreds of physicians treating tens or hundreds of thousands of patients and using computers to try and distill all that experience, all the successes and failures and the lessons that can be learnt, and make that wealth of experience available to an individual physician making a treatment decision for their individual patient.
The concept behind the RDI's approach is to use a large collection of patient therapy data to model the data and then use those models to predict the response of a patient to a combination of drugs on an individual basis.
So I think RDI play an important role in trying to give algorithms of care so that they can predict from simple data what subsequent drugs are likely to work.
And so the RDI approach is to say we can use the information which others have gathered as regards chance of success to really give that individual patient the best chance of success with those drugs which are available and allow the physician confidence in their choice of drugs that that's going to be the most successful choice of drugs for that individual patient.
We've had a long-term collaboration with the RDI. We've admired the way in which the RDI is set up as a charity and wants to improve outcomes not on the basis of profit, but on the basis of, what's good for humankind. And so we have used our quite extensive repository and our extensive knowledge of drugs both before treatment and what the response is after treatment to try and improve, with lots of other people, of course, the RDI computer system to give better predictions of outcome.
We're very pleased to work with the RDI collaboration because what we can do is we can provide a lot of data, especially data where people have had resistance tests, genotypic ones, and then certain treatments have been chosen, and then you can look at the outcome of those treatments. And also all the other data, the CD4, viral load, the treatment history data, can be put into the RDI model to help inform it, refine it, and make it better.
So for the RDI project to work, you need huge numbers of patients. So it's really great news that the partners together have contributed over 150,000 patients' data. And it's really that large number of patients which allows us to be confident in the accuracy when we are predicting what is the best choice of drugs for individuals who are failing treatment.
The RDI system is pretty accurate and is better than any genotype rule-based system.
So the models that are used by RDI are really very accurate. So they're accurate in predicting virological success at around about 80%. Now you can say 80%, is that really good enough? I think compared with other rules-based assessments based on resistance testing, those are actually quite incredible results. They actually say, actually this is better than a resistance test.
We felt the RDI, when we first developed these models that use genotypes, that it would be quite interesting to try and develop models without the use of genotypes, and particularly for use in resource-limited settings. This has been the focus of efforts over the last few years, and now we have models that don't require a genotype and are almost as accurate as the models that use a genotype.
The good news about the RDI, especially if you're in a developing country and you're trying to wonder what treatment to give next, is that it's about 80 to 85% predictive of how well you're going to do. So the RDI model, if you run it through the computer and it gives you an answer, you can then say, well, I've got very good confidence that this is going to get my patient undetectable in 80 to 85% of the cases.
In this country and most resource-rich countries would use the genotype, which would be accurate in predicting outcome around 65%. We use the genotype and then we use some rules to actually generate what is the best agent. Surprisingly, without a genotype, the RDI model predicts at 80% accuracy. So although this is a model which we're saying should be used in the resource poor world, actually you can see an argument for using it as a major contributor to choice of drugs in the resource-rich world as well.
We've attempted to assess the utility of the models in a real clinical setting in a number of different countries, including Canada and Italy, in a prospective way. And what we found was that the use of the models changed the physician's choice of combinations that they used to treat the patient with in about a third of cases.
So we've clearly here had a lot of experience. We've made lots of mistakes, as have others. And it's about taking that experience and actually making sure people don't repeat those mistakes. And I think the partnership with RDI allows us to translate not only our knowledge, but the experience of many, many patients who have lived with HIV, some of whom have died of HIV, and making sure that those individuals who are now in need of information allowing best choice of treatment can actually gain from that knowledge, from those mistakes made in many, many brave people who've lived and died from HIV disease.